Thanks everybody for joining today. Also, I'd just like to add to Rachel's, feel free to type a comment even if it's not a question and doesn't need an answer. As I go through the presentation, I'd be really interested to know your thoughts as well as questions. I'm the Director of Practice at SafeLives, and I just thought it might be quite useful to talk a little bit about SafeLives. SafeLives is a national domestic abuse charity, and we were established in 2005. There's about 50 to 60 people in our team, so we're not a huge organisation, and we've been working really hard since 2005 to clarify and embed a high-risk pathway for clients who are experiencing high-risk domestic abuse, and putting together a multi-agency response, which some of you will know as a MARAC. We've worked relentlessly over the last 10 years to try and do that, and we're quite proud of the fact that there are 260 plus MARACs across the country, and they're all still working towards the model and sending us information. What we did in 2014 is we reviewed our strategy and looked at the results, at the high-risk pathway and the impact that that was having on domestic abuse. And then we looked at our goals. And our goals are to halve the number of victims experiencing high-risk domestic abuse, halve the number of children, and halve the average time it takes to seek help. It was quite obvious doing that review that just to focus on high-risk victims wasn't going to meet our goals. So we've broadened our remit, and we have developed a new strategic priorities, which I'll go through later in the presentation. I think after that review, we just agreed that we needed to broaden our approach to safeguarding as a whole, make better links, identify more effectively and respond quicker. And I don't think many of us will argue with that. So today, the webinar is specifically looking really at older people. And I by no means pretend to be an expert on older people, but what I am quite useful at is looking at existing systems and trying to work out how we can make them more effective. So I spent a lot of the last 2 years visiting MASH hubs around the country, which predominantly look at child safeguarding, and working out how we could develop our understanding of that initial identification and linking vulnerability, risk and need in a more effective way. So I'm going to talk a little bit about our strategy to develop a one front door today. I'm going to probably use more stories than data in this presentation, because to be frank, there isn't a lot of data on this client group, and what we have got, which I will share with you today, definitely looks at older people through a domestic abuse lens. So not necessarily, and we don't pretend to be looking at older people across the piece, because we know there are a limited few that come into contact with domestic abuse specialist services. And just before I toddle on to the next slide, I just wondered if any of you are quite quick on the keyboard, if you could just start sending me a description of an older person, and not necessarily a definition that your organisation works to, but more of a description, because I think that might be useful at the end of the presentation to reflect on. So if a couple of you could do that, I'd be really grateful. So when I talked about the gaps that we thought were still existing 10 years after working tirelessly around high risk, there were some obvious gaps for us. So firstly, there's just no system that makes all families safe from domestic abuse. We were quite good at looking at specific individuals experiencing domestic abuse, and when they were engaging, working out how to effectively respond to them so they were safer. But we didn't really look at a whole family system, and there's some great practice going on, but there was nothing that was evidence-based that we felt we could roll out. We were also looking at kind of specific client groups within the terminology victim, and we also identified that children were a big gap, so specifically working with children, young and older people, victims who weren't assessed as high risk, so there wasn't really an embedded care pathway to be followed in local areas, and some standard risk victims identified with police were not getting any response at all. So it's almost like we're waiting for their crisis before we do anything, and I'm sure we'll all agree that's probably not what we want for our mother, and certainly not the best way to respond to domestic abuse. The other specific client group that we were interested in was victims who were experiencing other complex needs alongside domestic abuse. And we found from our work with Marek and our data collection and talking to Marek that Marek felt that it wasn't able to deal with such complicated cases in their 15-20 minutes because there was a lot going on, and they felt that they weren't responding effectively, and in fact these cases were becoming repeat victims and just going through the motions because Marek felt a little bit helpless to do anything. And also there was very little in place to challenge and change the perpetrator of domestic abuse behaviour. So you'll know that unless really there's a criminal justice order or that a perpetrator consents and on a very voluntary basis engages with a group, they're really left to run free and behave as they want. And this was also showing up in lots of our data looking at serial perpetrators where a perpetrator would just move on to another vulnerable victim. And this will be no surprise. We were looking across the country and looking at areas, and there was very much strategic overview of a locality looking at what would we need to do in this area so that we make our victims and their children safer, and we're confidently responding to them well, if not brilliantly. So that's how we've broadened our vision as an organisation, and that's the areas of work that we're taking forward. So that's what we said. I'm just going to move on now to what our clients told us. So there was a lot of don't pass me on, and this is a difficult barrier for all professionals really, because there's a fine line between working in your area of competence and just being a very good practitioner. But if we're working with a specific safeguarding issue that feels a bit complicated and that you need some expert advice, we often pass clients on. So that's my polite way of saying it. I'm also aware that there's lots of practitioners, and probably not the ones that have joined a webinar presented by SafeLives, that use this passing on as a way of dumping. So there's a kind of two school of thoughts really, is that practitioners don't feel confident to deal with specific safeguarding issues, and others that perhaps can't be bothered, and I'll leave that to you to work out in your area who fits into what bucket. There was a lot more of you know, we're treated as individuals and not really as families, and actually professionals see us as the primary issue, so the thing that they know about. So the thing that they know about might be substance misuse or domestic abuse or financial hardship, and professionals work with us as though that is what defines us and doesn't link all the other issues that are going on for me. And also, we had a lot of responses where families were up to their neck in professionals, didn't really know who was who and what they were coming in the house for, but at least they could count that on some occasions there were 8 who were coming back and forth their house over a period of time and weren't really clear on who was supposed to be doing what, but they seemed to take children off for an hour on their own for some play, so parents were happily relieved that they had a bit of respite. I don't think that's probably the way forward for us as a kind of state response to work with vulnerable families, and I know there are lots of areas now who are looking at single points of contacts for family and a team around the child and team around the family. So I think The last quote on there is from us, the DV organisation, is my IDVA saved my life, but my peer support group healed me. I think you can reflect that onto any safeguarding arena. So a professional can do so much, but there has to be a time that we allow people to move on and be people, where they're surrounded by other people that can help them stay buoyant, safe, and just generally enjoy life. And I think that's probably another area of work that we need to focus on. So I'm going to talk about data today. SafeLives is quite proud of the fact that we have the biggest national data set for domestic abuse. However, I'm not very proud when I ask the data team to look at what that means for older people. And as you can see, we've got 13 referrals to MARAC the year to September 2014, and I'm willing to bet my salary that there was probably more high-risk victims who were over 60 that year than 13. And also in our insights data, which specifically looks at specialist domestic abuse provision, there were 3%, older people represented 3% of that client group, and 3% of the outreach clients were age 61 or over. So that's pretty poor, and that's a SafeLives organisation looking at domestic abuse through a domestic abuse lens. But I'm a great believer as if we went to a social care organisation in an area and asked to look at their data, we would find huge statistics there. They might be wrapped up in a different language, and they might be called volatile relationships, and they might be called neglect. But if you dug deeper, I'm sure you'd find that there was domestic abuse written all over them. And I know that some of you will have heard from the Older People's Commission in Wales that's doing a bit of work that probably has got a better set of data looking through a social care lens, although that's quite a small number of people. So I'd just like to put this data into context and move on about what little we know today. Bearing in mind this is a domestic abuse lens, so all of the statistics that I'm sharing with you have come from services where primarily they present to the outside world as a domestic abuse service and not help the aged. So these are the statistics that we find when we're looking through that lens. And I think I'm quite interested in looking at the over 60 side of the profile of the clients. So if you look at all of the statistics, the current partners, the perpetrator is higher, male clients is higher, adult member is the primary offender is higher, multiple perpetrators not so high, and attempted to leave the perpetrator. So I'd like to just talk about attempted to leave the perpetrator for a bit. So under 60 is 68% and over 60 is 27%. And for those of us listening who are people, it doesn't really stretch your imagination to work out why that might be the case. And currently, the domestic abuse sector doesn't have very much to offer older victim who wants specialist support other than you probably should leave the perpetrator. Well, that might be okay when you're in your early 20s and you have the optimism of youth on your side, and perhaps there's a new life waiting for you that you could see. But perhaps as an older client, that doesn't feel quite such an exciting prospect, and online dating perhaps isn't the thing that floats your boat. So there are lots of barriers in over 60s, I think, in relation to what we need to offer that client group that doesn't talk about leaving the perpetrator for them to engage with services to increase their safety. The average length of abuse here for over 60s is 6.5 years. I would say that's probably because of the client group that are engaging with domestic abuse services rather than a reality. And if you listen to advocates on the ground who are practical professionals working with this client group, they will give you lots of cases where people have experienced abuse for 30 and 40 years. It's just where we find those that client group, and I probably think is not here at the moment. We'd have to do some work to be a bit more confident about that statistic. And I think the other bottom four are kind of the types of abuse that the different client groups are experiencing. And there's a lot of conversation to be had with those. So sexual abuse is a lot lower. Physical abuse comes out exactly the same. I think sexual abuse we can talk about, but I'm not very confident in the 10%. I think that's probably a conversation that's easier to have with younger clients and perhaps easier to disclose for younger clients. Stalking and harassment is a lot higher for under 60s, and that might be kind of lost in a dialogue with older clients. And I suppose if more of them are still in a relationship, harassment and stalking falls into perhaps the jealousy and controlling behaviour for them. So the data, I've got a health check here because I think we've got a long way to go with data before I would feel confident that it reflects a client group of over 60 experiencing domestic abuse, although I'm confident that it reflects those that are using domestic abuse specialist services. So I will move on. So I wonder if anybody sent a description in of an older person, because I just thought, having rattled through some data about what over 60 looks like and what under 60 looks like from a data perspective, I don't think that helps us very much as professionals who are trying to get on and do our job. And I think when we start using labels of any kind, you will have all heard this before, but I just think it's quite useful to remind us. So if I talk about what an older person is, so I've got an older person that's Pat, 79 years old. She uses the same hairdresser as me. My hairdresser is a mobile hairdresser, and my hairdresser went to her house and found lumps on her head when she was doing her hair. And Pat told my hairdresser, it's been going on for years, he always does it. He hits me when he walks past me if I haven't done something right. And you know what men are like. So my hairdresser is a professional going into the home and came to my house and kind of knows what I do and said, what can I do for this woman? I wish she'd never told me. I can't sleep at night. And when I cut his hair, I just want to stick the scissors in the back of his head. So I thought, that is a professional going into that environment who's not trained in anything other than probably to give you a really cool hairstyle. How can we give people like my hairdresser some tools that help her help Pat? I think that's a bigger question, but Pat certainly would fit into the older client group when we think about an older person. I'd also ask you to think about, I wonder what other professionals Pat sees in her day-to-day life at 79. She has a mobile hairdresser because she's not mobile and can't get out of the house. So imagine somewhere there are professionals from social care involved. My other example would be Trevor. So Trevor's a 70-year-old who is married to an ex-head teacher of a private school, and when I spoke to Trevor, he had a big wound in the front of his neck, and we were talking about how that happened, and he said, it's all right, I don't mind, she tidies me up for when the family come round. She doesn't like the folds of skin hanging over my collar, so she pulls my skin through the buttonhole in my shirt and then puts my tie on to keep it all nice and tidy. I think Trevor is probably a victim of domestic abuse and probably fits into an older person category. I don't know what happened long term for Trevor, but short term the police were involved and social care started talking about respite and capacity. and the police involvement fizzled out. So there, Pat and Trevor, just a few kind of examples of what an older person is. But I just thought it'd be interesting for me to share with you what Google told me an older person was. And I think this is so useful in our line of work, because I spent a lot of my professional life talking to people about domestic abuse and asking people to describe how they might identify domestic abuse. And it always comes down to somebody that's not very well kept, probably has got bruises that are visible, might use alcohol and might smell a little bit. Well, actually, that's not the definition of people experiencing domestic abuse, as I'm sure everyone on this call knows. But when we think about what it means to be an older person, when you qualify probably to be an older person at 55, because you can get sheltered accommodation then. And if we just look at the people on the screen and think about how we clump that age together, so 55 to 105, you'll all meet the definition of an older person. However, you won't present the same. So my question really to you is, does that help us when we talk about such specific safeguarding issues like domestic abuse and older people? Do we already start designing in our head the type of people that we'd ask about domestic abuse if we bumped into them in our professional and personal lives? So I don't think for 1 minute that you're going to bump into Steven Seagal, but if you did, I mean, would he be somebody that you might ask if he felt safe at home? I doubt it very much. I think it is helpful, though. It's helpful for us to do two things. It's helpful for us probably to do three things, to be aware that when you're working with older clients, that you might enter into a world that you're not as confident with. So you might start hearing things like ageism and carer fatigue and self-neglect and respite. And if you're traditionally from a domestic abuse service, that might not be terminology that you're used to. And like everything, as professionals start to get kind of a bit worried about that, because if other professionals are talking the language you don't quite understand, it seems always a little bit harder to do our job. So I would ask you to kind of just forget those and just start thinking about people are people. And all those are just words that the sector that works with older people is comfortable with. So just ask what they mean and work out how to translate what you're worried about. I think it's helpful because it helps us think about whether we're a strategic policymaker or a politician or a practitioner. It starts to help us think about where we might look, because we're going to have to look for older clients. They're not going to be banging on the door asking for a service. So I think it's useful for us to think about in our own communities. If I was an older person and I was experiencing domestic abuse, where would be the places I frequent, and what type of information could I get there that helps me move a smaller step towards being safer? I think I'm all about the practical, and if every one of us went away off this call and just did that, that would be a huge step in the right direction. I think it's also helpful to learn that language and understand that world if you don't normally live in it. It's helpful because it helps you get resources, and it helps you talk to statutory organisations and understand their statutory obligations. And I think in a time of limited resources, it's always very useful to be able to talk the language and understand the legal obligations to negotiate the response and the resources that you just might need to make all the difference. And I'm all about asking what older people think as opposed to what practitioners think, because I expect some of us fit in that category ourselves, but probably haven't got that head on when we think about it. So there's a few quotes here, and these are quotes from older people that have been spoken to in a health setting, and I think that's probably another good place to start looking in our communities for older clients. So what's what can we offer older clients that sounds useful so they don't often continue their engagement? And I've touched on that earlier. I think the other one is about the perpetrators often are a relative. Um, and that is a little bit complicated, but that doesn't mean we can't do anything about it. We just need to start thinking about how we work with that family as a system, because leaving or ending or moving might not be something that an older person with capacity is going to consent to doing. So it might be that we'll need to link arms with other organisations and think about that family as a whole if we're going to do anything useful with them. I think the wasting our time, there's a couple of reasons, isn't there, why people think this. I don't think this is just for older clients either. I think there's a lot of people that think things have to be a 999 incident for you to waste people's time. But I think in this context, if you have been an older, if you're an older person who's experienced years of abuse, then you will have minimised uh, this abuse, and there will be a kind of narrative in your family, whether your children are older and moved out, but that will have been around then, and there will be some way that the family has managed that dynamic, and there will be a narrative around it, and it might go like, well, you know what dad's like, or you know what she's like. And it might be that older family members try and help out when they can. And there's also that thing about, why are you saying this now when we were all children and at home and you didn't do it then? And that's quite hard for a parent to look at older children and have a transparent conversation with. However, I've fallen into our kind of stereotypes, and I've gone to the world where older people have been in long-lasting traditional families for 30 years. I'm just going to kind of rein myself in on that and think about, people are vulnerable through all stages of their lives, and people are getting married more and more. So this might be a second, third, fourth marriage, or a partnership, and people come from non-abusive histories but are vulnerable because of bereavement or financial reasons, and haven't got any of the life skills that you might have picked up if you were experiencing abuse for longer. So I don't necessarily think they're more at risk. I just think we can't allow ourselves to go down that kind of traditional route and be happy that we've got the answer for that client group. I think I just probably will bang on about, we can't rely on older people coming to us. We do really need to go and find them. And I'm just going to do a case study to kind of try and make this real for everybody. So the slide I've just put on your screen, and you might need a couple of minutes to sit back and then get a bit closer because it is really busy. But I'm going to talk you through the slide and just try and bring to life how I think we're going to have to broaden our remit and be a bit more proactive if we're to reach older people and do something useful with them. So the context of this genogram, which some people call a horrendogram, is that Oliver and Charlie are kind of either side in the middle and in navy blue bold boxes. They're adult males, and everyone in a bold box was in scope for this piece of work that we did for a local authority not so long ago. And the people involved predominantly were Oliver and Charlie. So Oliver and Charlie were found in suspicious circumstances, dead in the same house. And the local authority, which I would add, I would consider are very coordinated and work very well collaboratively as a multi-agency response, identified that they'd like somebody independent to come and look at this after the dust had settled, to see how they could improve, and because they weren't aligned when they were looking at what had happened to Oliver and Charlie. So Oliver and Charlie died in the same house on the same day. The house that they were in was Nicola's, so she's pink, bold, and Nicola and Dylan are in an intimate relationship, they're boyfriend and girlfriend, and they were there too. So the four of them were there, and Oliver and Charlie died. Oliver and Charlie had been both discussed at a multi-agency risk assessment conference 8 years previously, and on the same day in the same area. And the strategic decision makers in that local authority wanted to ask SafeLives to do some work and find out what the links were. And it was just coincidence. There were no links. So Oliver and Charlie had been in abusive relationships. They had been abusers 8 years previously with girlfriends, and they didn't have any visible contacts or relationships with each other at that time that we could find. But it did help us do a huge piece of work. So we looked at Oliver, Charlie, Nicola and Dylan, and we looked at them for the last 8 years since they had been heard at Marek, and just to find out at what points did that local area know anything about those four individuals. So they were in scope. And if you look at the key, there'll be pink boxes underneath some individuals with a number in, and that shows how many times they've been at Marek. And the cross sign is obviously very settled for aren't with us anymore. So I'm going to just ask you to concentrate on Oliver. So we looked at Oliver, and the information that we could review was not from the police, not from the criminal justice system, and not from the prison. So no CPS, no police, and no prison. We didn't have that information. So all the criminal justice information we had come through other sources. We did have access to Marek, domestic violence specialists, mental health and substance misuse, and social care. And all of that information was held on the same database in that area. So what we did is we'll look at Oliver for the purpose of today. And if you can see, Oliver's previous girlfriend was Lexi, and Lexi had been to Marek once with Oliver, who'd been 3 times. So Oliver died for a drug-related death, and when we looked at his last partner, her name was Jessica. Jessica and Oliver had been heard at Marek twice. From the Marek minutes, we started to explore what was going on for Oliver and Jessica, and social care had removed Jared, Theo and Oscar. No, that's not true actually. Jake, Jared, Theo and Oscar's father had parental responsibility for the children, and Jessica had consented to that. So Jessica, for the purpose of social care lens, was living alone, and the children were with Jake. Jessica was frequenting Oliver's house a lot, and Oliver and Jessica were using substances, both drugs and alcohol. And Oliver was a dangerous offender and was military trained and had a huge violent previous convictions with the police. So Oliver, we were looking at Oliver's Marek minutes, and there was mention of Phyllis. So Phyllis is not involved, so she wasn't in scope. She was Oliver's mum, but we just had a nose about because we can't help ourselves. So I'd just like to talk to you about Phyllis, and I'd like to walk in Phyllis's shoes. So what did we know about Phyllis? We didn't know very much at all. We knew she was 86. We knew Oliver was her primary carer, and he lived in the same house as her from the Marek minutes. And we knew that Phyllis was having a lot of Oliver's girlfriend's kids frequenting the house, and they were boisterous and unruly and causing some problems with the neighbours, and were eating a lot of her food and were wrecking her house. And we also knew that within the last 12 months of Oliver, before Oliver died, that the ambulance was called to Phyllis's house 28 times in 12 months. So we were intrigued about that, and we started to think about what that meant. So we looked at social care and what social care thought about Phyllis. So social care had recognised Phyllis as a vulnerable adult, and there was a plan in place around Phyllis, and the offshoot of the plan really was to spend some more time with Phyllis because Phyllis was isolated and lonely, and she was self-neglecting because her falls were due to her trying to get out of the bath or fall out of bed or fall down the stairs, and some of those social care thought were alcohol related. So the result of that was for Oliver to be with Phyllis more, so she had some company, and also looking after her financial affairs because that was a bit chaotic. I just want to show you the next slide. So I'm not going to go into this, but this shows you of the 4 people that we looked at in some depth over the last 8 years who had what communication and contact with what organisations. And I think that is quite useful to see the trends and patterns. So we can't say we don't know anything about these individuals, but I'd really like for you to look at Oliver. So I talked about Oliver. I said 28 ambulance call outs. I think I might have been exaggerating by 1, maybe, but I don't know. I'll double check that. So if you look at Oliver's history and where Oliver and his linked family and friends were accessing in that local area, from 2008 there was a lot of children's services involvement, and that was around his previous girlfriend's children. And you can see that there's very little on criminal justice because we couldn't access their databases. But what we do know from police and Marek is police were aware of Oliver and his dangerousness and offending behaviour, substance misuse too, and the domestic abuse specialist, the IDFA, had been involved with Oliver's partners. The Marek, I've banged on about that enough, but adult safeguarding were involved, and if we look at that year before 2014, on 3 of those occasions the paramedics were concerned about Phyllis in a way that they were worried that Oliver was aggressive on site when they got to the call. He wanted to be with Phyllis all the time and was reluctant to leave her alone to talk to professionals. So on 3 occasions that year, they flagged concerns, safeguarding concerns to the vulnerable adults team, and the vulnerable adult team looked into that and looked and spoke only to Phyllis and Oliver. So Phyllis didn't disclose any domestic abuse, and Oliver was keen to be involved with her care, and I've already explained what the outcome of that case was. So what I think that I'm trying to say here is I don't know that Phyllis will ever attend a domestic abuse specialist service on her own steam. I think we're going to have to be smarter at looking at safeguarding issues. I'm just going to give you the numbers there and quickly move on. So as you can see, this piece of research looked at those 4 people and the contacts that they had, and we can only imagine how expensive those cases are to resource and how ineffective we spend that resource because we're not as aligned as we should be. So this is Phyllis, and back to my small practical steps, because I'm going to go on to the one front door and talk about that for 5 minutes. But small practical steps, I just think in your profession, whatever that is, what can you do as an organisation or as a professional to think about an older person involved with cases that you're involved with who isn't perhaps directly accessing your service but is definitely on the outskirts and living a life that Phyllis was living? So I said that I'd finish off just talking about our one front door model that we've been developing, and we've got the opportunity to start piloting in the next couple of years. And it is hugely ambitious, the one front door, but it is definitely the way forward. However, I think this is probably a long-term plan. So if anyone's looking for a quick win, this one front door won't be it. So building on our MASH experience that we've had as an organisation, where we've looked at those predominantly focused on child protection, thinking about Phyllis and knowing what we know about domestic abuse, mental health and substance misuse, looking at too many serious case reviews and domestic homicide reviews and not learning lessons about information gathering and sharing, as just a society, as just a response, we're going to have to get better and we're going to have to be smarter. And that's going to be a huge step for us as organisations, both voluntary and statutory, on a culture as well as a systems and processes way. So what we're saying the One Front Door will do, it'll be a place for all referrals from anybody. So our vision is that any safeguarding concern identified by anyone, whether that be a self-referral, a concerned neighbour, family or friend, would end up at the One Front Door. Now, I don't think for 1 minute this is one door in your community that somebody pushes open and says, hello, One Front Door. What I think this is going to develop as is a central point that sits behind all of your community access points. So whether that'll be a domestic violence specialist, a mental health a support service or children's services, those routes will still all be there, and they have, lots of them have already got the trust and rapport with the community, and why would you take them away? But the model that we're looking to develop in our 7 sites is a hub that sits behind all those access points. And as soon as we have a safeguarding concern that is high risk or with consent, that everybody in that area signs up to letting the One Front Door know. So if you just think about the enormity of that, when we just think about referral pathways and how we're all finding the volumes of child protection referrals, for instance, and vulnerable adults as that world gets a bit more sophisticated. So thinking about the volume, that's quite an ambitious task, but there are many strategic groups around the country that are very willing and extremely keen to take this model forward, so that we are really identifying safeguarding concerns and making those links as soon as possible. Why this is different to a troubled families provision or MASH provision is that we won't necessarily have to hit a threshold to find that information on linked people. So I'm going to give you an example with Phyllis. So if that paramedic that was concerned about Phyllis on the 17th time there in 12 months had flagged to adult services their concern in a One Front Door area, adult services would have made the One Front Door aware straight away, and the One Front Door would have run a intelligence gathering process, which would have looked at Phyllis, looked at her address, looked at the concern, and then asked every agency at the earliest opportunity to do their research, so to look at their databases and see what they knew about Phyllis, what they knew about Oliver, what they knew about the address and any linked children. And they don't share the information of what they need because we wouldn't have a legal authority or framework to support us to do that, because we'd be sharing information about everybody for anything, and nobody wants to live in that world. But we have used a system that is used for terrorism in different countries, where each agency would just assess the information that they have on Phyllis or Oliver or one of the children, Jared, Theo or Oscar, and they would allocate what the information that they'd heard, so Oliver's being aggressive at scene and reluctant to let professionals talk to Phyllis, they would know that information, and they would know Phyllis's date of birth and her address, and they would scan their systems, and if they found nothing, then that would be a useful exercise that's worth doing to kind of start focusing on what we know. But if they found some information, they would allocate a RAG rate into that. So lots of you who've been involved with MASHes will be aware of this, but it would be blue, red, amber, green. And they wouldn't share the information. They would just say the information. So police might say the information that we hold on Oliver, we would assess Oliver as a red. We think Oliver is a dangerous person and poses a significant risk to an 86-year-old vulnerable person that's fallen out of bed 17 times this year. And Children's Services might look at what they know on Theo and find out that they don't actually know that Theo's frequenting Phyllis's house because Theo's living with Jake, and there's no information that says that Jessica's having Theo over the weekend. And they might assess Theo as amber because they haven't got any current incidents. Or probably they would just assess Theo as green because they wouldn't have any current worries, and they haven't had any reports from Jake that anything's going wrong for those children. So you can see just at the very initial stages of a one front door that we would start widening our safeguarding net and not looking for single domestic abuse or single mental health. We're starting to look at people in a family, people as a system, people as people who've got very different issues going on for them, but somehow they're all connected. So before, perhaps like in the case that I've spoken about Phyllis, so before social care go and do some further interview or assessment with Phyllis, they would be in possession of a whole raft of information that helps them talk to Phyllis in a way of understanding and knowing her situation with Oliver, and perhaps not be recommending that Oliver is her primary carer and spends more time with her. The visual that I'm showing you is just a simple way of talking about the process that I've just talked about with Phyllis, and how that would make us much more assertive and proactive in looking for safeguarding and linking the risks. So I'm just going to go through some slides because I'm aware of time, and I'm going to leave this. The slides will be there for you, and I'm happy to take any questions, but this is just the aim of our one front door in some words. And another kind of just practical health check from me is there's something that we've managed to do as professionals and policymakers and second tier organisations is to make things sound so sophisticated and complicated that no one has enough skills and training to actually do them. I'm not a believer of that at all. I think all safeguarding issues are all about the relationship, they're all about the conversation, and they're all about the questions. And you might not be a specialist domestic abuse worker, and you might not be a specialist working with honour-based violence. But you have got common sense, and because you work in this world, you know how to build up a rapport and trust with people, and you should think about all the opportunities that you might have to just keep calm and keep asking questions. The majority of our clients tell us, if you ask, I'll probably tell you, but if you don't ask, I'll never tell you. I'd just be mindful to ask questions when people are on their own, because you can't assume who's safe and who's not safe. So just to finish, I'm just going to kind of give you some questions to go away and perhaps have a conversation with your colleague or on your own. Where would you look for older people experiencing domestic abuse? And what in your area does working with a whole family mean? Because I've seen lots of whole family approaches, and from my perspective, I see a lot of mums and children being worked quite intensely with, but I see very few men and grandparents and wider family. So think about your whole family and how how does that work. Not many families just work with mums and children, especially when mums are sometimes the ones that have the least influence to change things, especially when we're asking them to change. I'd also ask you to think about where older people might frequent in your community and how we start to talk to them about domestic abuse in a language and an environment that feels safe for them to engage with us. And the last question, which if you've got the answer, I'd really like to know it, is what interventions are effective with older people? And the Butterfly Project that Margaret Smith has done a podcast, sorry, I'm all over the technology. She'll explain how she's working with older people, and also the Silver Project has done a blog. It'd be worth looking at that. But I think we'll all agree that there is no evidence base. There's no brilliant way of doing this work yet. We have come a long way, but we have a long way to go with older people.
Fab, thank you, Jo. We've had a couple of sort of comments and questions come through on the chat. So a question about whether you think having an IDVA based in adult services would be a kind of step forward in terms of linking domestic abuse and adult social care.
So from my experience, it's never a bad thing co-locating anybody with anybody. I think the trick is to not think co-located necessarily means collaborative. So I've visited lots of MASH where you have a, a lot of different agencies sitting in different pods, never talking to each other and using the same door in and out. And I've also heard the phrase safeguarding issues traded, not shared. So I am less concerned who sits where and more concerned about the how. So it may be that you could make those links with safeguarding in your local area and have a lead IDVA who does a lot of communication, does a lot of awareness training, both sides of that. So your domestic abuse service and your local safeguarding teams are better aware and work together. I think there are lots of creative ways you can do that. I would avoid always putting an isolated person in a big team where they are the only person for a long time, because I think there's a case where you feel quite lonely or you go local, so you end up actually thinking you're working as part of the vulnerable adults team. And there will be lots of examples where that's happened with IDVA working in police stations, but there are also lots of examples where that's worked well. So my opinion is yes, always good to mix up the multi-agencies. It's just about the how.
Muting myself. So a comment here from Amanda in Cambridgeshire about police and community safety partnerships in Cambridgeshire use a system called eSINs, which allows different agencies to share information about an individual and can search and address, etc., used by police, housing, children's social care at the moment, but have looked at expanding to domestic abuse.
Amanda, I think absolutely. I think the IT is critical to this. So whatever databases, and I think we use eSINs here for our project for Drive with perpetrators too. I think there are some really useful pieces of gadget that help us do that. And I always think if my computer, when I'm playing Candy Crush, can work out that I'm still interested in those high knee-high leather boots that fit my wide calves after 5 weeks that I haven't searched for it, surely as a safeguarding response we can work out how to link Phyllis with Oliver and share information to professionals that help them do a better job. So I think it's critical to progress in this work.
And another comment from Bunmi, talking about one place for all referrals, especially statutory agencies, might prevent this client group from making disclosure, as some do prefer the voluntary agencies, especially when not wanting to leave the relationship.
Yeah, that's exactly why I think that the one front door sits behind those existing referral pathways. And I think in the domestic abuse sector, we are well versed in having conversations with our clients to reassure them that children aren't removed and that we're all working to make them safer. But they are barriers, both culturally and societal, that are still there, and one front door is not going to change that. We're going to have to work our socks off to work with our workforce and our client groups to overcome them.
Okay, cool. And then another comment from Amanda about Action on Elder Abuse launched their EARS service in Brighton earlier this year, which is Elder Abuse Resource Service, and plan to expand it to other areas. So it'd be good for us to link in with. Thanks, Amanda. We will kind of make contact with them. That might be quite a useful link if we can put that out on social media as part of the spotlight as well. So thank you very much, Jo, and thank you, everybody. So all the resources for the spotlight on older people are on the SafeLives website. If you have any questions that you've not been able to ask, or things that you think of later, then just drop an email at knowledgehub@safelives.org.uk and we can respond to you there. Okay, thank you.